This episode of Transmission Interrupted was recorded October 24th, 2024.
This is Transmission Interrupted, the podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Welcome to Transmission Interrupted from NETEC.
Hello, and welcome to Transmission Interrupted. My name is Jill Morgan. I'm a nurse here at Emory University Hospital in Atlanta, and I am part of the biocontainment team here. For those of you not yet familiar with NETEC, our mission is to set the gold standard for special pathogen preparedness and response across health systems in the U.S. with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. NETEC works alongside and in cooperation with the CDC and is funded by ASPR, the Administration for Strategic Preparedness and Response. On today's episode, I am joined by two great guests, Dr. Bente, professor in the Department of Microbiology and Immunology at the University of Texas Medical Branch, and Dr. Saima Ali, who's the head of the Department of Emergency Medicine in the adult section at the Indus Hospital and Health Network. I am thrilled with this episode because I don't know a whole lot about Crimean Congo hemorrhagic fever, or CCHF, but it is one of the viral hemorrhagic fevers that would probably qualify for most of us here in the United States as a special pathogen, and one that has a pretty complicated viral life cycle, history, and geographic reach. So welcome to the show, Saima and Dennis. I'm super excited about this and to learn more about CCHF with y'all. So Dr. Bente, for those who struggle with geography, I don't think I could find Crimea or Congo on a map without some assistance. Can you help us sort of understand the geography, where CCHF is a risk, and maybe a little bit about how it got this sort of awkward name?
Hi, Jill. Thanks for having me. Sure, yes. So Crimean Congo hemorrhagic fever derives its name from the geographic location where the disease was first identified. Like so many other arboviruses and hemorrhagic fever viruses, it's always the place where it was first recognized. And then subsequently, it was recognized to be caused by the same virus. So the disease was initially described in 1944 in the Crimean Peninsula, and it was called Crimean hemorrhagic fever. And it was due to an outbreak amongst Soviet army military personnel. So the German forces had occupied the Crimean Peninsula. This is an area in the Black Sea in southwest Russia. And when the Soviet army came back in and reoccupied basically the area, 200 people or so got sick. And that's when the disease was first described. Then later in 1956, a similar hemorrhagic fever was identified in the Congo basin. And this was then known as Crimean Congo hemorrhagic fever. And it took probably until like 1969 until researchers discovered that the virus responsible for both Crimean and Congo fever were actually antigenically the same. And consequently, the two names were combined to form Crimean Congo hemorrhagic fever. So the naming convention highlights the historical and epidemiological link between the two regions where the disease was first documented.
It's fascinating that we have these two sort of disparate areas that then get linked by this virus. And that is cluing me in that perhaps there's something that's moving around these areas that is responsible. So can you fill us in a little bit like the life cycle? Because I think perhaps some of the other pathogens that people are used to in the United States, at least, things like Lyme disease, right? Where a tick might be what makes you sick, but it has a really complex life cycle before it gets to that point. And I really don't understand like the livestock tick link in all these things.
Sure. Maybe I can just add a little bit more about the geographic distribution, just to set the stage. Crimean Congo hemorrhagic fever virus is the most widespread of all of the medically important tick-borne viruses. And it's the second most widespread hemorrhagic fever virus after dengue virus. And it's found on 3 continents, in Asia, in Africa, and in Europe. We don't see it in the Americas or in Australia. And it's found in many different countries. And, I mentioned earlier that it was discovered in the Crimean Peninsula and then in the Congo. But since then, it's been discovered in many, many, many different countries. Coming back to your question of the life cycle. So the virus basically lays dormant or hides in a life cycle between the tick and the vertebrate host. So mostly livestock, but also other mammalian species can also be found in some other non-mammalian species. And the virus goes back and forth between the tick and the animal host. And it doesn't cause any disease in the animals. And that's why I said laid dormant, because we don't notice normally, right? The animals don't get sick. They get bitten by a tick. They don't show any clinical signs. And that's why there's a circulation of this virus in nature, but nobody really notices the presence of the virus because there's no disease, neither from the tick side nor from the animal side. So it silently circulates in this tick vertebrate cycle.
Wow, that is very sneaky. So thinking about these in livestock, I guess I don't really think about a tick going from one animal to another. I think about it staying on an animal and sort of having its fill, if you will, and grossly, and then dropping off, I suppose. But are there intervening things? Like, I know birds eat ticks off of things sometimes. Like, is there something more complex? Because otherwise it seems like if you could sort of isolate it in livestock herds, I don't know even if we have testing for things like that, but it would seem like we would have been able to put some sort of constraints on this, but it doesn't feel like we have.
That is correct, yes. The transmission often depends on the tick species or the multiple species that can transmit the virus. So there are certain ticks that are host-specific, like you said, so they stick to one host or one or two hosts. They're very specific to certain animal species, and they will not prefer any other animal. And then there's certain ticks that really are generalists. They feed on a variety of different hosts. And that's the case for Crimean Congo. So the main tick species or the main tick genus that transmits Crimean Congo hemorrhagic fever virus is the genus Hyaloma. And they do prefer livestock, but they also feed on humans. Actually, they're pretty aggressive ticks. They actually like to feed on humans. So whenever cow or cattle or something like that is not available, they will also feed on humans. And that's the moment when the virus is then transmitted to humans. So there are certain other tick-borne diseases where the ticks that transmit the disease maybe only feed on certain animals and don't go onto humans and feed on humans. But with these Hyaloma ticks, they're very aggressive towards a lot of different species, including humans.
Wow. One more thing for me to be creeped out by is this idea of aggressive ticks towards humans. That is an awful thought. So can you take us into this chain where the human is interacting? So obviously people who work with livestock, people who are working in abattoirs or farmers, and who else? Is this something where if I'm hiking in one of these places, or, what is my risk if I'm visiting? I mean, this is a huge swath of the world, Asia, Africa, and Europe. That's a lot of space. And so fill us in on this environmental human interaction.
Sure, yeah, absolutely. So yes, Hyaloma ticks will feed on humans, but they do prefer livestock or certain other species of mammals. So if you're in the perimeter or in the proximity of livestock, that's your typical risk factor. So farmers or people working the fields, veterinarians, shepherds, people working in those areas, they are typically the ones at risk, and not hikers or people just randomly passing by. They are typically not the ones bitten by those Hyaloma ticks. So you have to be in somewhat close proximity to those animals. And then there's also the second route of transmission that you hinted at, and this is through the blood of infected livestock. So there's a short period when sheep or cattle or goats or something like that can be viremic. So they will have the virus in their bloodstream. And when the animal is slaughtered at this point, there's a risk for humans in the slaughter process to acquire the virus through mucosal membranes or through skin lacerations or things like that when they get the viremic blood of the animal. So yes, there's a risk in slaughterhouses or abattoirs and so on. It's lower, typically, because the most common transmission route is the tick bite, but it's definitely a possibility of getting infected.
Wow. Okay. So now tick bites, I know that in humans, very often, I'll mention Lyme again, because I think that's the tick bite that many, many people in the United States are familiar with. But frequently, we are seeing people who perhaps don't recall a tick bite. How memorable is this tick bite? Is there something else about the presentation or the tick itself? Does it make a secondary infection where the bite was, or make some, with Lyme, we think about that bullseye kind of demarcation. Is there anything to help us that this might be a dangerous situation as opposed to just your garden variety tick that we can perhaps take off and not worry too much about?
Unfortunately not. So there's no pathognomonic sign as you described, right? Like the bullseye redness that you see after a bite with a Lyme-infected tick. First of all, the good news for us living here in the US is that these hyaloma ticks are not present in the US or in South America. That's the good news. The bad news, obviously, for the rest of the world is that these hyaloma ticks are present. And you're right, a lot of the tick bites go unnoticed. There are studies that have been conducted in the Mediterranean where they say that at least 30% of all tick bites go unnoticed. And that's just a feature of a tick, right? Like ticks feed for a long period of time and they stay hidden during that time. So they put all effort into being unnoticed. They have all of those factors in their saliva to numb the area, to not cause any itch or redness or something like that. And that's why we don't notice them. Often we just notice ticks by accident, right? You undress and you see the spot on your body. So ticks are very good at staying hidden.
All right, I'm liking them less and less even now. So last question before we sort of move this conversation into more of the healthcare realm. And that's really about this idea of many people not knowing about their tick bite. So it sounds like CCHF could be more common in more people and places. Is there reason to think that people are exposed to CCHF or have a mild case of CCHF and may never know it at all?
That's certainly a possibility. And the more awareness there is of CCHF and the more testing we do and the more diagnostic capabilities we develop, the more we see that there are subclinical infections. In the past, the perception was that it's a very high percentage of cases do clinically present and cause hemorrhagic fever. But the more serosurveys we see from highly endemic areas, we see that quite a number of these cases are subclinical or maybe cause some sort of an unspecific mild disease. And the people don't report to the hospital. They might come down with some flu-like illness and then don't go to the hospital. So that's certainly a possibility.
All right. Let's move into the people who do end up looking for healthcare. So Dr. Saima Ali is going to join us. So you work in emergency medicine. So certainly you're on the very front line of trying to do that, identify, isolate, inform, kind of screening folks. Welcome, Dr. Ali, and tell us a little bit about what this looks like in presentation. And are there pieces of the history, whether that's in the identify, isolate, and inform model or in taking a history, that sort of clue you into you might want to be thinking about CCHF in your differential?
Thanks, Jill. And it was certainly enlightening to listen to Dr. Bente because as clinicians, we don't really think about the poor ticks and their life cycle. And it's surely frightening, as you've said, to think about what havoc can be created by them. Moving on to the question that you've asked, living in Pakistan, and that's where I work, a lot of the problems arise from the fact that we're basically an agricultural country. So livestock for 85% of the population is a normal way of life. So daily exposure to livestock, having birds in the house, having cattle near to where humans live is something that we're very familiar with. Moving on to the urban population, if animals are kept at home and they are slaughtered, not taking the right precautions, that's where we see the outbreak of viral hemorrhagic fever, especially CCHF. So people presenting with CCHF can be in multiple ways. So as it is a viral illness, those who are presenting to us in the incubation period, in the pre-hemorrhagic phase of the disease itself, present with simple viral fever symptoms, like they would have body aches, they would have fever, they would have sore throat. Some of them would have pharyngitis, conjunctivitis, slight belly pain, mild rash. And as you said, that many of them, since viral diseases are quite common and all of these symptoms are more or less the same, seldom go undiagnosed because you are really not suspecting CCHF in every patient who presents to you with these symptoms. However, those who are in the hemorrhagic phase, they present with high acuity. They are usually very sick. They have deranged liver enzymes, so they might appear jaundice. They might have anemia. They have low platelet count or thrombocytopenia, so they appear to have particular rash. They bleed from their venous puncture sites if they try and take their blood for sampling. They have conjunctival hemorrhages. They're really very, very sick people. But the downside of working in a country where the load of infectious disease is more than non-infectious diseases is that a lot of other diseases also present with similar symptoms. For example, complicated malaria would present in a similar way, or sepsis would present in a similar way, or fulminant hepatic failure would present in a similar way. So the diagnostic dilemma for us becomes, whom do we isolate and whom do we not isolate? Because with limited resources, it is quite an uphill challenge. So we have developed protocols where extensive history taking, physical examination, and even the slightest suspicion of having a viral hemorrhagic fever alerts the physicians, the nurses, and the infection control department. And we ensure that the right precautions are taken, not only for the safety of the patient, but also for those who are caring for them. Moving on to the treatment modality and the diagnostics. Diagnostics basically involve running the appropriate tests like a complete blood count, liver enzymes, looking at their kidneys, sending blood cultures again, because we need to rule out other differentials that we might have, running a malaria test, a dengue test, because dengue, again, is very common in our setup. And basically ensuring that all these samples are collected in a proper way. The lab staff is appropriately alerted. They are transported in a safe manner, following the guidelines that are recommended by WHO and CDC, and ensuring that we have a rapid turnaround time so that appropriate disposition can be decided for such patients. And if there is exposure to the healthcare providers, that certainly giving them post-exposure prophylaxis.
So I want to sort of link these two conversations for just a second, thinking about, for instance, the risk to healthcare workers. So Dennis, you told us that during this period when the livestock are viremic, they've got a lot of virus circulating in their blood, and that's why it's dangerous for people who might be slaughtering animals or handling fresh animal meat. And now Dr. Ali talking about the risk to healthcare workers in this viremic, I assume, phase when people are in the, not perhaps in the very low early symptoms, but once you've developed some more acute phase of the illness, I would assume that that's when they're going to be most viremic. And is the risk strictly to exposure to blood and body fluids? Or is there, for instance, are these people exhaling virus? Is there virus in other body fluids that we should be concerned with? Like, where do we need to concentrate our efforts and perhaps not go in the full space suit? But am I just worried about an exposure in the laboratory or when I'm drawing blood, or really kind of trying to pick that apart a little bit?
Sure. I think that you can see this from two different perspectives. I think, first of all, Crimean Congo hemorrhagic fever virus is a Bunya virus. And Bunya viruses are typically, generally speaking, not transmitted from human to human. There are a few exceptions. Crimean Congo is one of them. Andes is another one. There are now reports for some other viruses too, but typically it's not a virus comparable to Ebola virus, for example, where we have large amounts of virus in the vomit or in the diarrhea or something like that. So Bunya viruses are typically, they're not shedding as much as maybe some other viruses. I think that's fact number one. Number two is, you brought up the animals. Keep in mind that an animal does not get sick. So an animal will clear the virus. it's able to handle the virus very quickly. And that's why the viremia is typically short-lived and it's low level. Whereas in humans, when they progress, as Dr. Ali mentioned, into the hemorrhagic phase or even in the pre-hemorrhagic phase, they have large amounts or high numbers of virus particles in their bloodstream. And actually the level of viremia is actually also correlated with the severity of the disease. So people with a very severe disease typically have very high levels in their blood. There's a limited numbers of studies have looked at other ways of shedding the virus. So I'm thinking about saliva or sweat or vomit or diarrhea. That's typically not where the virus is found. Having said that, though, we see that transmission in a nosocomial setting occurs when high-risk procedures such as blood draws or intubation or something like that are done without the proper PPE. So, no masks or no gloves. Probably there's no awareness at this point that this is a hemorrhagic fever or Crimean Congo hemorrhagic fever. And that's when we see the transmission. But once the awareness is there and once the proper PPE is worn, that's when we typically see that these clusters of infection break down and disappear. So the good news for us is that the virus is not doesn't present to these very high numbers in bodily fluids and can be contained with proper PPE quickly.
Excellent. That's the one piece of good news you've been able to give me today, Dr. Bente. All right. Dr. Ali, really interesting that this looks so much like malaria and dengue and some of the other things that would be just so common in many parts of the world. And that we need to be aware of in the United States because they're getting closer and closer as the world warms up and people travel. So tell me a little bit more about the clinical course. How can I, as a healthcare worker, help intervene so that this doesn't progress, that these people have a reasonable outcome from CCHF?
That's a very good question, Jill. And classically, what we've seen, as Dr. Bente was mentioning, that as the exposure to animals increases, the chances of humans acquiring the disease also goes up. So there are certain times, for example, where animals are sacrificed, right? So during those days, we are more alert because we know that people are coming in contact regularly with animals, and there is a very high likelihood of them acquiring CCHF. So alerting your people beforehand that the seasonal surges are anticipated, and any person coming in with the red flags that we have all talked about should be looked at more carefully, a detailed history of exposure. And the funny thing in our setup is that people will never, ever remember the exposure, right? So if you go back into the history, they would not remember being bitten by a tick because they would think it is a mosquito bite or it is some other insect, and they've probably just brushed it off and forgotten about it. So that is something that we emphasize upon. The other thing that we emphasize upon, as Dr. Bente has already said, that wearing appropriate PPE saves lives. So irrespective of what your differential diagnosis might be, wear the proper PPEs. Even if it turns out to be malaria, if it turns out to be fulminant hepatic failure, if it turns out to be anything else, at least you know that if it would have been a viral hemorrhagic fever, especially CCHF, then you've not only saved yourself, but your coworkers and your lab staff by raising the proper alerts. Another thing that we found useful is holding periodic refresher courses or workshops for our healthcare providers, because you need to keep on reinforcing these principles of wearing PPEs and acquiring the specimens correctly. And if you need to do invasive procedures like putting in a central line or putting in an ET tube, an endotracheal tube, if you want to ventilate them, or taking them for a surgical procedure, somebody with CCHF might also have a broken bone in an RTA and requires immediate surgical intervention. So what do you do? How do you ensure the safety of not only the staff working in the emergency and the lab, but also those taking care of the patient post-operatively as well as during the surgery itself? So there are multiple steps that need to be thought about in taking care of these patients. And having the best outcome, not only for them, but also for your own self and for your staff. Just in case if you have a patient who's been diagnosed with CCHF, another important thing is if your staff has been exposed, then you need to do the proper line listing so that the people get post-exposure prophylaxis. And also you need to line list the immediate family of the patient, because those have also been exposed to the patient or their secretions or their blood while the patient was at home. So you need to have proper line listing. You need to give proper prophylaxis, not only to the healthcare providers, but to the community, and alert the relevant authorities so that the disease can be contained.
Wow. All right. So you touched on a couple things I want to go back to for sure. One is this idea of prophylaxis and treatment. So I want to ask about what our treatment options are. Now, I know that when I was caring for Ebola patients, I come from a fairly non-medical family. And so when I told my family that, we basically could only offer supportive care, I know that what my mom thought was that basically I was sitting at someone's bedside and patting their hand. And I think people don't always understand that when we say supportive care, we're really talking about supporting vital organ systems, whether that's with fluid resuscitation or blood pressure support or with ventilation, and certainly things like a renal replacement. What can we offer CCHF patients in terms of treatment? And also, I would love to have one of the two of you or both talk about testing. What is the availability of testing? What does that look like in the United States in something that we probably don't see very often?
So as far as you're taking care of the patient, like tender loving care definitely needs to be there. You need to be supportive, not only to the patient, but to their family members, because talking about it in a calm, quiet, closed environment such as this is very different from standing at the bedside when the patient is spitting out blood and is vomiting out blood and they have blood coming from their nose and all their other orifices. So it's a very daunting, it's a very traumatic sight for the family as well as for the healthcare providers. So making sure that everybody is in a good space, not only physically, but also mentally, that is one thing that is important, and I don't think we talk about it as much as we should. The second thing is if somebody comes in with overt symptoms, as you've said, you need to support their vital organs, giving them fluids, giving them blood products, giving them inotropic support if they're not making enough blood pressure. But also ribavirin, which is an antiviral, has been recommended by the CDC as well as the WHO in people who have viral hemorrhagic fever, and 30 milligrams per kg intravenously as loading dose can be given, and then we can run an infusion. Similarly, if the staff has been exposed, you can also give ribavirin 500 milligrams by mouth every 6 hours for 7 days, while ensuring that none of your staff members is pregnant and, has other ailments that might prevent them from taking ribavirin. For the diagnostics, the thing that we commonly use is a PCR. So PCRs are done for diagnosis of CCHF. Antigen detection might be available in some centers. We do not have that. And again, viral cultures, if that is a possibility at your center, then definitely go for it. But the thing with PCR is that the turnaround time is fairly quick, so you get to know early on. But with cultures, you need to wait for a longer time period. You need to weigh the appropriate availability versus what can be done without the diagnostic test available in a resource limited setup. So I think it's the call of the people who are actually dealing with the disease and the availability of resources at their end.
Yeah. And I assume that many of our facilities could probably do a rapid malaria test, but malaria would not preclude having both infections. Right. Okay. Dr. Bente.
Yeah, I just wanted to give the virologist's perspective on the treatment and diagnostic, basically echoing what Dr. Ali already mentioned. But I think the limiting theme in all of this is where the cases present, because they are typically in rural areas, very rural areas, or areas with very low infrastructure. And typically the cases in the past have been very sporadic. And so often the needed treatments and diagnostics are not available in those areas. And I think that's one of the limiting factors that we always forget about. There have been, in terms of treatment, there have been attempts in the 60s and 70s when there were outbreaks in Bulgaria and in southern Russia and so on, where they developed a vaccine against CCHF, where they used hyperimmune sera to treat the patients. And you can imagine that this is, decades ago, and this was not up to the standard that we see nowadays with the certain regulatory aspects that we want from products and treatment options. But because the case numbers have increased with CCHF in the last 2 decades, there's been a renaissance of the development of new efforts to treat the disease. So there are currently new vaccine approaches, there are monoclonal treatments that are being investigated and are at different stages in the testing. So kind of like the same approaches that have been used in the 60s, just with the state-of-art development that we have nowadays. But the issue, again, coming back to the availability of those. So ribavirin has been suggested. It's probably efficacious if it's given early, but then you also have to have accessibility to ribavirin, right? And I don't think that IV ribavirin is really available in many places. Even oral ribavirin is often not available in very rural areas. So it needs to be given early. There needs to be the proper algorithms, clinical algorithms to give ribavirin early on. And I think that's the limiting factor for a lot of the things that we do with CCHF. But I think as the case numbers are going up, we will see more and more products coming out and being available in a lot of places around the world. And maybe just a few words in terms of diagnostics. And I can just really echo again what Dr. Ali said. PCR is the gold standard. This is a BSL-4 virus, so virus isolation is really out of the scope that you want to do, right? So you want to do PCR. Antigen testing is often not available, so there's no rapid blood tests that you can do compared to malaria or something that we talked about earlier. So that's one of the issues that we're having, that rapid tests are often not available and PCR has to be done.
Yeah. So it sounds to me like we need to do a really good history taking. We need to be thinking about, when we talk about identify, isolate, inform, that identify is really getting, here in the United States, a travel history, but also an exposure history. What unusual or what experiences have you had that might put you at risk? So hearing that somebody works on a farm, or hearing that somebody here in the United States might have traveled, this idea of like organic farm travel trips that people are on, I think it has just mushroomed over the last few years. And we see people that are having these experiences in parts of the world and probably putting themselves at least in contact or in areas where this is a possibility. So to me, it's just really emphasizing that, opening up that first initial history taking to really be thinking about what somebody might have. And then, as you said, Dr. Bente, I think, we have sites in the United States that could probably turn around a PCR test fairly quickly on some of the panels that have been released over the last few years. But with other places, this is going to be a sent out test to a reference lab. And with all due respect to those, that turnaround might be days. So if I can summarize a little bit from Dr. Ali, it sounds like good supportive care in good PPE. Go ahead and treat for the things that you have the ability to treat for, whether that's malaria or if you have access to ribavirin. It sounds like a reasonable thing if this is in your differential list. And intervening early enough that we can keep someone from getting to that bleeding from everywhere, really looking like a viral hemorrhagic fever in name patient, where we know our chance of having good outcomes drastically is reduced. Are there any other pieces we really want to talk about CCHF and the clinical course of CCHF that you want to get across today?
I just would like to add one more point, and that is, what if you lose the patient, right? So there are certain instructions that need to be given for the proper burial versus whatever means of taking care of the body is decided upon. So those instructions need to be in place to ensure that the people taking care of their loved one once they have passed away are safe. So I think that's the final chain that needs to be discussed and informed to the people, not only healthcare providers, but also to the family to whom the body is handed over, and alerting the appropriate authorities in your own country, in your own region, in your own hospital is important, because the escalation of care or the escalation of, being aware is important. So what if I'm getting cases? So I need to inform other hospitals in my vicinity, in my city, in my region that we are beginning to see. And that's the general norm that we follow, that if we start seeing patients, then we start alerting and raising the right alarms, because escalation of care and escalation of awareness is linked to not only providing care to the patient, but also ensuring that the family as well as the healthcare providers are safe.
Yeah, fantastic point to really think about. That patient's been with some folks, right, in their family units, in traveling, and how that pathogen affects that group, whether they need to be cases that are observed and watched to see if they develop symptoms, but also the tragedy of losing someone and not being able to perhaps use your normal familial rituals and patterns with that deceased is really difficult. And I think even here in the United States, where we unfortunately see many, many deaths within a very clinical environment, not being able to mourn in the way you're used to is just a devastating added insult to this. So really important. Thank you for mentioning that.
Yes, and I wanted to thank Dr. Ali for bringing or for raising the point of awareness again. I think we also have to think about the fact that it's a tick-borne disease, so there's seasonality of the disease in many parts of the world, not in all parts of the world, but there's seasonality. So there should be the awareness that at certain times of the year, the case numbers will go up. Dr. Ali brought up also the ritual slaughtering. So if there's some sort of a religious festival coming up where you see an increase of that, the awareness should also be there. But I think with the changes, the global changes that we see in climate, and I think we should also expand our differential diagnosis in areas where we haven't seen CCHF. And that's where the awareness should be there, that there could be cases of CCHF in areas where we typically haven't seen it. And I just wanted to add that on, that the awareness of what time of the year, what associations the patients had maybe with livestock, and then maybe we should also add it to the DDX in certain areas of the world where it wasn't really present, but it might be present in the future.
Yeah, great points. I think that whether it's tick-borne or other vector-borne or influenced by our interactions with our environment in some other way, all of this is getting closer and closer and closer. And there are fewer places that can think of themselves as immune. And certainly that's one of the things that I think here in the United States, when we think about the identify piece of that model, frequently people think about bad things only coming from other places. And certainly that's something we would like to disabuse people of that notion, because it certainly is not necessarily true. And even if you feel like it's been true, it won't stay true, because it's all moving around our small planet very quickly. Well, I just want to thank you guys so much. This has been so interesting. I am not a tick fan, but I think that this has been a really in-depth conversation about how this gets from this tick to its livestock, to blood in the livestock that might be slaughtered, and then into the humans that are interacting with that, whether you're bitten by the tick or have an exposure to the blood of animals, either that you are butchering or that are butchered as part of a ritual, whether you're out and about in these areas where this kind of thing might occur, and there's this aggressive tick that's going to preferentially perhaps decide that you're looking tasty that day. Really interesting that this is how this pathogen starts, and very different, I think, for those of us who are more used to the idea of an Ebola or a Marburg, where we're talking about bats and things like that. So fascinating. It also makes me really want to emphasize that early supportive care even if someone has been identified as being at risk for a viral hemorrhagic pathogen, there is not an additional I in there that says put them someplace and ignore them, right? We need to extend life-saving care early, and that means we need to know how to put on appropriate PPE. In this case of CCHF, we want to make sure that we're wearing eye protection, gloves, mask, gown, that we're protecting ourselves from blood and body fluids as we would with other things, being super cautious with things like needle stick injuries, things like that. But that we probably have a little less risk than we do with something like an Ebola or a Marburg, where the viral infectious dose might be tiny, and that we need to think about that sort of total body coverage that we would with some other pathogens. So respiratory protection, eye protection, gloves, gown, and then really expanding our differential list. No matter where you are taking in patients, you want to think about expanding your questioning and that early interview process to make sure you're capturing these exposure potentials, whatever they might be. So thank you guys so much. This has just been fascinating.
I just wanted to thank you. I think it has been a very interesting discussion. And just to emphasize what you've said, prevention is better than cure. So it's always good to be on the lookout if you're a healthcare provider, in no matter what capacity you're functioning, to make sure that you and your colleagues are all safe for the betterment of not only the patients, but also of their families.
Thank you, Dr. Ali.
Yeah, I think what's important to me is to mention that I think there's often with CCHF is this projected fear that this could turn into a pandemic, like we've seen with respiratory viruses. I don't think that potential is really there to see these pandemics. At the same time, though, with our changing world and with climate change, we've seen really a dramatic rise of cases of Crimean Congo, and not only an increase, but also popping up of new cases in new areas. And we see an expansion of the vectors that transmit CCHF. So I think you hit the nail on its head, right? Like the awareness needs to be there that it might be expanding into new areas. But I don't think we should approach this with fear that this will be the next pandemic.
Yeah, that's a great point, to think that we have a lot of things on our radar that we feel like might be the next pandemic, whether that's H5N1, which I don't really have as great a concern about as some other people, whether it's CCHF or whether it's some new pathogen we haven't even thought about yet. The idea that perhaps the risk of that is a little less with CCHF is great for the larger population, but that each individual healthcare worker needs to be thinking about how they protect themselves and being aware and making sure that we're on the lookout for these things. So I want to thank Dr. Bente and Dr. Ali for sharing so much of this information about CCHF, Crimean Congo hemorrhagic fever, with us today. We hope, all of us hope, that you will keep these things in mind when you are seeing patients anywhere, that there are things out there that we need to intervene with quickly and that we need to protect ourselves from being in contact with. So please, I know there's a lot to do in ERs and doctors' offices and primary care clinics and urgent cares, but taking that first history and really understanding what somebody might have been exposed to is just so, so important. All right. For those of you listening at home, thank you for tuning into this episode on Crimean Congo hemorrhagic fever. We hope you'll join us for future episodes on a wide range of topics, from healthcare worker safety to personal protective equipment, and even more about infectious diseases of all kinds. If you have any questions for NETEC or ideas for future shows, please feel free to contact us at info@netec.org. You can find us on the web at netec.org/podcast, where you can subscribe to future episodes and find even more information on today's topic. We hope we'll see you next time on Transmission Interrupted.
You've been listening to Transmission Interrupted, the podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Learn more at netec.org.